This webinar was recorded for subrecipients of the Tennessee Strong Families Grant on January 22nd, 2025. Chenoa Allen, PhD, Senior Evaluator at SWARPS, and Maria Fishwick, BSN RN, Registered Nurse Navigator at the University of Tennessee, were our subject matter expert presenters. This training was designed to inform subrecipients about the diverse immigrant populations who live in Tennessee, discuss unique traumatic experiences faced by immigrant families, help subrecipients familiarize with community and government services available for these families, and understand and apply culturally competent strategies for working with immigrant families in the community. The slides and reference materials are posted on our webpage for your reference and review.
It's nice to talk to you all today. Thank you for your interest in this topic. I am kind of the academic research side of things, and I'm going to give you kind of an overview, Immigration 101. Who are we talking about, and how many folks are in the state, in this population? And then talk some about trauma and the risk of child welfare involvement in immigrant families. And then Maria's recorded presentation is more, she's a practitioner, she's a registered nurse. Her presentation is more about kind of her experience with best practices and resources for working with limited English proficiency families. So this probably will feel like maybe a lot of information, but I want you to kind of get a big picture of the size and the diversity of the immigrant population, both in the state and across the country. So as of 2023, there were 208,000 kids in Tennessee with a foreign-born parent. So one or both of their parents was an immigrant. And that's 14% of all Tennessee children. So not a majority, but still a pretty big group of kids. Only about 14,500 of those kids were born outside of the US themselves. So the vast majority of these kids are born in the US, they're US citizens, they have all the same rights and responsibilities of every US citizen. There was a recent executive order that attempts to change that. It can't change by executive order, so this is the way things are right now, unless the Constitution changes. There are a lot of different immigration statuses. I'm not going to tell you about all of them, but I'm going to give you a few examples so that you can see kind of the diversity of how people come here and what their rights are while they're here. So legal permanent residents, we also call green card holders. So we talk about people having their green card. Those are people who have permission to stay in the US forever, unless they like commit a felony and are convicted. And they can become US citizens after 3 to 5 years in the US. So they're here legally, they can stay potentially forever as citizens. And then we have refugees and asylum seekers, which are different, but have some similarities. So they're both groups of people who are fleeing persecution or violence or natural disaster in the country that they're from. The difference is that refugees go through all of the screening before they come to the US, and asylum seekers come to the US and then they apply. Both are present legally in the US and both can eventually become citizens. The differences in experience between those two groups are actually quite large once they're in the US and kind of going through the screening process, but we don't need to talk about all of that. You can ask questions if you're interested. And then, so those first three groups are people who potentially can stay in the US forever. And then we have some groups of immigrants who are here temporarily. And these are just a couple of examples. There are others like students. People with temporary protected status are kind of like refugees and asylum seekers, except that they can only stay in the US temporarily. They can't become citizens. And then we have like temporary workers, like agricultural workers, technology workers, who have permission to live and work in the US. They can bring their spouse and children, but they're, again, here only temporarily. Eventually, they will have to go home. Unless in some other way they get a green card. And then we hear about, and then we talk about kind of the group that we hear the most about on the news. So DACA, undocumented, unauthorized, illegal immigrants. Folks with DACA are adults who are brought to the US as a child. And the US says, we're not going to deport you for now. You can work, depending on where you live, you can go to school, but you can't stay forever. You can't become a citizen. You have to pay to renew your status every couple of years. So status of DACA is constantly in question, so the program could end. But for now, we're not going to deport you. And then we have undocumented, unauthorized, also called illegal immigrants who have no legal permission to be in the US. They can be deported at any time, can never become citizens unless they're a victim of domestic violence or some other, again, kind of statuses that we don't need to go into here. So the point of this slide is there's a big diversity in how people come to the US, how long they can stay, what their experiences were before they came, and what their experiences are once they're here. There's also a group of kids, unaccompanied minors, who you could encounter either as children or as young parents. These are folks who are under age 18. They don't have a parent or legal guardian in the United States, and they're undocumented. And they do enter the child welfare system. So you could encounter them again, either as a child in care or as a parent of a baby born here or that they brought with them, if they're under 18. This shows the legal status for Tennessee's immigrants, and this is different groups than I just told you because this is kind of the only data I could find that broke it down. So about 40% of immigrants who live in Tennessee are citizens. They came typically as a green card holder or a refugee or an asylum seeker. They did all the things they needed to do to become citizens, and now they can stay forever. And then about a third are undocumented immigrants. So these are the folks that are most at risk of being deported and separated from their kids. And then a variety of other statuses in the smaller pieces of the pie. There's also a lot of diversity in where people are from, right? So we typically think about immigrants being primarily from Latin America. Maybe we also think about immigrants from Asia. And this chart this chart shows that there's a big diversity in where folks come from. So about half of immigrants in Tennessee are from Latin America, Mexico, Central South America. About a quarter are from Asia, and then we have also immigrants from Africa, Europe, Northern America, so Canada, Mexico is not included there, although part of North America, and then Oceania. So a lot of different countries of origin, a lot of different languages that people speak. It's not just Spanish. And there's a poll that just popped up about where are the immigrants that you serve from, right? So it looks like you're mostly serving immigrants from Latin America and Africa, also some immigrants from Asia and Northern America. So you're not just serving Spanish-speaking immigrants, you're serving immigrants who speak, in addition to English, some other languages. And in Maria's part of the presentation, she has some resources that can help you work with immigrants just regardless of their language. So like language lines that you can call. All right, so that's kind of an overview of who are immigrants. Now I want to talk about the traumas that immigrants experience and the risk of child welfare involvement. So in 2010, which is the most recent data I could find, only about 10% of children involved with the child welfare system had a foreign-born parent or caregiver. So if you remember, I said 14% of Tennessee children have an immigrant parent. So they're less likely to be involved in the child welfare system than kids whose parents are born in the United States. That said, they encounter barriers that you can probably guess just based on your experience working with immigrants in your own practices. Things like language barriers. So children can be placed in families that don't speak their language, things like that. I'm sure you're all familiar with ACEs from other trainings, so I'm not going to go into the kind of general information about ACEs, but the chart on the right shows the ACEs that we typically talk about, things like physical and emotional abuse, physical and emotional neglect, divorce. When we look at these ACEs, there's not a whole lot of data on the experiences of immigrants. I found one study of Hispanic kids, so kids primarily from Mexico, Central and South America, and in that study, 16% of children of immigrants reported at least one ACE, compared to 30% of kids who have a US-born parent. So we're seeing lower rates of ACEs in children of immigrants. And another study of children who were in mental health treatment Refugee kids were exposed to more types of trauma than other immigrant kids or US born kids, especially things that are characteristic of the refugee experience, like being forced to leave home, experiencing community violence, traumatic loss, death of a parent, or separation from family. Other immigrant youth who are not refugees had similar ACE scores to US born kids. So we're not seeing typically higher ACEs among immigrants, with some caveats. Um, this chart shows the prevalence of ACEs in immigrant adults and US born adults and children of immigrants. This is a study of adults, but it's asking, of course, about their childhood experiences. The red line is first generation immigrants, so those are people who moved to the US themselves. The dotted blue line is children of immigrants, and the solid blue line is non-immigrants. So they and their parents were both born in the US. And what we see is not a huge difference in ACEs between any of the groups, but we do see higher rates of ACEs for immigrants for the traumatic experiences related to neglect. So things like being related to neglect or related to kind of being treated as an adult in the household. So things like having to do difficult or dangerous chores, being left home alone, going without things that they need, going hungry, not getting adequate medical treatment. So when we talk to adults, we're seeing higher rates of neglect, but lower rates of kind of physical, emotional, sexual abuse. The differences are not particularly large. And this could be, we'll talk about kind of the reasons for this in just a minute. Poverty is a big part of the picture. So that's all about ACEs. But ACEs aren't an exhaustive list of all the traumas that people experience. And some of the traumas that immigrants are most likely to experience aren't reflected in ACEs. So for immigrant families, we think about trauma that occurs before, during, and after migration. Of course, if we're talking about kids who are born in the US, they only experience those after migration traumas. They're not going to, of course, experience migration themselves. Although they will potentially also be exposed to intergenerational trauma. So this is where the parent is the parent or even the grandparent is exposed to trauma. The chart on the right kind of walks you through this. The parent's mental health is affected by the trauma that they experience, maybe anxiety, depression, substance abuse. That affects their parenting style. So maybe they develop a neglectful or an authoritative parenting style, which then traumatizes their child. And the child experiences those traumas of physical, emotional abuse, neglect, as a result of their parents' trauma. So, so when we're talking about kids who are born in the US, we're mostly thinking about after migration trauma and then intergenerational trauma. And of course, intergenerational trauma is not only something immigrants experience. So to give you some examples for a couple of different groups of immigrants, when we think about refugees, asylum seekers, temporary protected status, people who are fleeing violence or conflict, before they migrate, they're exposed to that conflict and violence. They may experience sexual violence, of course, is high in war zones. They may experience loss of a parent. They're all forced to leave home suddenly. During migration, they may have difficult, dangerous travel to a refugee camp, poverty. Conditions in refugee camps often are not great. They can't decide where they're resettled, so they don't choose to come to the US. They go wherever the UN sends them. Um, and they may wait for a really long time in refugee camps, up even decades. And then after migration, they have high rates of poverty, language barriers. Children can be forced to take on adult roles, especially if the child speaks English and the parent does not. They may be asked to translate in situations that is not appropriate for the child even to have the information. And that is true for kind of all immigrants where the parents don't speak English well. We can think about undocumented immigrants before migration. They're leaving their home country maybe because of poverty, unemployment. Often the children are being pressured to join gangs, and so the parents leave with their kids to avoid getting involved with gangs. During migration, if they cross the border illegally, the border crossing can be really difficult. Sexual violence, physical violence, having all your things stolen, being afraid of being caught. And then after migration, poverty and low wages because they can't work legally in the US, a constant fear of being deported, and then if a parent is deported, that child and parent are often separated, although the child could leave with the parent. Um, so those are the traumatic experiences that kind of lead into risk for child welfare involvement. And as I'm talking about this, the image on the right is a guide for immigrant families developed in New York State to help them avoid child welfare involvement. It's an older text, it's from 2008. It is about New York State, but I'll show you the table of contents in a minute. I think it can be really helpful for us to help us think about the kinds of things that we want to educate parents about if they're new to the US. So, one risk factor for being involved with child welfare is cultural differences in what's considered acceptable parenting, right? So, in the US, we have standards about what kind of physical punishment is allowed. We have standards about how old a child needs to be before they can be left home alone, what kind of tasks are appropriate for a child to take on in the family. But those norms aren't the same everywhere. And so, families may come to the US and they're treating their children the way they would treat them back home, and they don't realize that it's not considered acceptable here. Um, Parentification, so the older children taking on roles as kind of a third parent in the household, is obviously not limited to immigrant families, but can be really common if the parents are both working a lot. Um, so one of the things that this guide talks about is kind of educating parents on what is considered acceptable parenting in the US and what they need to do in their family to avoid being charged with abuse or neglect. And then, as I've mentioned, poverty rates are often really high in immigrant populations, especially the more vulnerable, undocumented DACA refugees. Um, Families often may not have a support network in the US, so they don't have parents or grandparents or aunts and uncles here who can help them take care of their kids, which can lead them to leave their kids home alone or or what we would consider neglect their children. And then we also see some medical neglect. So, like there are different standards for parenting, there are different expectations for when you seek healthcare and what kind of healthcare you seek. And so parents may be charged with neglect if they are not kind of understanding and bought in yet to the Western medical system. There's high levels of distrust in medical providers, especially for refugees who maybe experience violence from people in authority, and from undocumented immigrants who are just really trying to fly under the radar. Um, there are different, like I said, different norms about what's appropriate medical treatment. There's some resistance to some medical services, again, not limited to immigrants, but things like vaccines. Um, Many families, kids and parents alike, don't have health insurance, and so they can't afford to go to the doctor. It can be hard to get to the doctor. Um, Undocumented immigrants don't have driver's license in Tennessee. So even if they do drive, they try to avoid driving except when it's absolutely necessary. Maybe they don't understand how the bus system works. And so they need somebody to teach them how to use the bus system if they're in an urban area. So we can help these families by, providing education about the healthcare system, helping them get health insurance if they are eligible, helping them find places to go for free healthcare if not, helping them learn how to navigate the bus system or get their driver's license if they are able to. So this is a table of contents from that guide. It can be helpful, again, it's not going to be exactly Tennessee laws, but it can be helpful for us to think about, what is and is not acceptable, who the laws apply to, what happens, educating parents about what happens next if you are subject to a child abuse report. So this report or this guide is linked in the resource sheet that Brooke will send out. Just a couple more things. When we're talking about poverty and lack of health insurance, there are some services that are available for immigrant families. There are some organizations across the state that serve immigrant families, but but there are also some programs that other parents are eligible for that we can refer immigrants to. So low-income pregnant mothers are eligible for Cover Kids or CHIP, no matter what their immigration status is, because we're insuring the baby. so they can get pregnancy-related care and they can get postpartum care for 2 months. After birth, they can, this helps kind of streamline getting their child enrolled in teen care or cover kids. And these mothers are also eligible for WIC, so for nutrition support. Um, Kids who are born in the US are eligible for all of the public benefits that any other child is eligible for. So TANF for welfare, teen care, cover kids, food stamps. Um, these kids can be enrolled in those programs regardless of their parents' immigration status. Currently, although I haven't looked at the news today, currently enrolling in these programs doesn't affect their parents' immigration status. That could change. It has changed in the past. It has changed back. But for now, we should encourage immigrant parents to access teen care and other benefits for their kids when they're eligible so that we can reduce neglect due to poverty. Um, Everything in this presentation could change next week, which is why I don't talk a whole lot about services that are available, but this is kind of how things are as of today. And then there are some resources on this slide that are also linked in the resource sheet that you will get after this.
Are you looking for questions that would specifically ask about specific resources?
At the front door.
Sure, if you have one, Tabitha, yeah, that'd be great.
Yeah, so I have a client that I've been trying to assist who speaks Uzbek, and she's pregnant. And I not only do we have a significant language barrier, and she uses Google Translate, so she actually prefers communication in text in English so that she can translate it. And I'm just trying to figure out how to get her assistance for insurance so she can access health care for her pregnancy. I've encouraged her to go to the health department to talk with Chant, but I don't. I feel like she either doesn't understand or doesn't that's the first step, or they're not able to help her because of the significant language barrier with the Uzbek. I'm looking for some guidance and like what can I do for her? I've even tried to reach out to um like immigrant healthcare. There, I can't think of the name. Siloam, I think, is the healthcare free healthcare provider. Internet Nice. I've tried to reach out to them, but I wasn't able to reach them. I've even given her that information so that she could call and talk to them.
I wish Maria was here because she has really the on the ground experience. I know she mentions in her presentation language line, which can help with translation when you're talking to her, although I think it has some cost. But the
Yeah.
health department should be able to use language line when they work with her. I think this is a question we should send to Maria, because she's agreed to answer some questions by email because she's been doing a lot of work with vaccine access and helping limited English proficiency families access healthcare as a
Okay.
nurse.
Is there possible for you to put Maria's email in the chat and maybe I could email her? I mean, I don't want everyone to inundate her, but
No, that's totally fine. I was thinking I will compile all the questions, and so I took yours down, Tabitha,
okay.
and then I can follow up with like an email to everyone because I'm sure, some other organizations may be experiencing some of the same, similar situations. So that way everyone can kind of see the answer that she gives as well.
Yeah.
But she is going to hit some of that stuff in the video that we're about to play.
Okay. No, normally, I mean, like everybody in the poll, normally the immigrants that we serve are Latin American. And a lot of times they've already been to the health department. They're coming to the pregnancy center for pregnancy test verification and ultrasound. And then they go back or, they've applied for, cover kids or whatever they're eligible for. And they're already starting that process. This one is presenting so many barriers, and I largely probably because of the language barrier, cultural barrier, and I feel lost because I don't know how she's approaching, halfway through her pregnancy, and she hasn't accessed care, and she doesn't feel good, and I'm like, I'm feeling as a clinician, I want to help her get that care that she needs so she can be evaluated by an OB.
And you mentioned Nice. Does that mean you're in the Davidson County area?
She is.
Yeah.
Yeah, I mean, we have a center in Davidson County. We have, and then we're out in Wilson County, but I believe she is in Davidson. I can double check.
I asked because one of Maria's colleagues does similar work to what she'll talk about, and she is in the Nashville area. And maybe if you want to share your email address, you can maybe even just chat it directly to me. I can connect you with Elizabeth, who may have some ideas more
Okay.
local because Maria is in East Tennessee.
Okay.
Yeah, that's a great idea too, Chenoa. I was going to say, I know that, the Registered Nurse Navigator program is statewide. And so if there's any of you all who are, again, dealing with a specific issue like that, we're more than happy to connect you with the Registered Nurse Navigator in your area that can probably help find more local resources too. And then we do have one more question in the chat, Chenoa. What do you suggest case managers at nonprofit organizations do when they become aware that an immigrant client or family is undocumented?
Mhm. Yeah, so assuming that your goal is to protect that family, frankly, I would not record that information if I can avoid it. Um, I would help connect them to, if you don't feel comfortable kind of understanding their rights and what services they can receive, connect them to organizations in the state. And I can, um, by email, could help you kind of figure out who that is in your area. Um, I would find out if any of the children in the family are born in the US. Kind of work with the parent to understand that it's okay and currently safe to, enroll their kids in Medicaid, sorry, TennCare and other programs, that their child is just like any other US citizen in that way, and they can access those services. Um, I feel like that's not a super thorough answer, but I also things are changing so quickly right now related to immigration that I don't feel comfortable going a whole lot deeper than that, when I might have had more to kind of say about it 6 months ago when things were not changing so quickly. But my first approach is to not have written records of information I don't want that might endanger the folks I'm working with. Um, yeah.
Okay, thank you. All right, so we'll move on to the second portion of our presentation. Again, Maria is so sorry that she couldn't be here today, but it's the sickness time of year that hits us all, unfortunately. And so I'll go ahead and just introduce her, and then we will watch her video part. So our second presenter, Maria, has been a community registered nurse navigator with the UT College of Nursing since February 2023, and she currently covers 7.5 counties in Tennessee. The goal of the grant that Maria works on is to increase immunization rates across the state, specifically in the rural areas with underserved populations. She's been a registered nurse since 2013 and is currently in school working towards a master's of public health with a concentration in community health education and epidemiology.
Hello, everyone, and thank you so much for joining me today. I just wanted to introduce myself. My name is Maria Fishwick, and I am a community time working with limited English proficiency families over the last couple years in my current position. As I said before, my name is Maria Fishwick, and I'm a registered nurse. I've been in the capacity of nursing in some way, shape, or form since 2010, and I've experienced in several different settings, including inpatient hospital setting, ER, mental health, outpatient clinics, public health nursing, and also academia. Like I said, my position currently is a community registered nurse navigator. We're working on a grant-funded program from the Tennessee Department of Health to increase routine immunization rates in children and adults in Tennessee. Our focus is currently on counties with the highest need determined by the SBI, but we do have nurses in every county. I'm going to talk to you all a bit about interpretation and translation and why it's important. And I do want to note that we commonly hear these words being used interchangeably. However, they are two different things. It's important to use these terms properly so we show an underlying knowledge of these practices, which also results in increased respect and increased trust. I'm going to talk a bit about translation and what that means. We use the word translation when we're talking about written content, and translation services usually go one way. So we're going to be going from English to Spanish, but we don't need to translate anything back. It doesn't happen in real time. Often we have translators take our documents home to the office, and they use computer-aided tools and reference materials as needed to make sure that these documents are appropriately translated and are understandable. Some of the examples that need to be translated can be consent forms, applications, notices of rights, and letters that require a response. So when do we use translation? As you can see, there's several different areas when we do use translation. And I specifically wanted to point out marketing materials because I do think that is super important. If we're trying to reach preferred or targeted audiences, we do want them to be able to read the content that we're trying to give them. Also, educational handouts. Something that I found helpful is that I will research and figure out the top 3 languages that are spoken in the county that I may be working in at the time, and I will print education in all 3 of those languages in hope to create vaccine equity for everyone in that area of focus. Some other opportunities to use translation are online scheduling and communication like email, social media posts, and prescription and follow-up care instructions. An example of translation gone wrong and why we need to ensure proper translation and understanding is this one right here. In China in the 1980s, Kentucky Fried Chicken slogan, "Finger looking good," was mistranslated into "eat your fingers off." And as you can see, that could be an issue. Another example of a huge translation error was HSBC's bank slogan was mistranslated from "assume nothing" to "do nothing," and for a bank that is not a good look. So this cost a $10 million rebrand to be done for that bank. Costly mistake for a mistranslation. Now that we've talked briefly about translation, I want to go over to interpretation. Interpretation is used when we're talking about spoken language in real time. Interpreters must be able to easily switch between the languages, so we want to make sure that our interpreters are fluent in both languages. Interpreters listen to the spoken word and rephrase without changing the speaker's original meaning. And they must capture the idioms and cultural references in both languages and interpret them appropriately. Offering translation and interpretation services demonstrates an organization's commitment to health equity, and in turn, this can create a more welcoming and inclusive environment, leading to increased client retention and satisfaction, which at the end of the day is what we all want, and it's our goal. I wanted to share this quote from Maya Angelou. I think it recognizes the importance of equity, regardless of our differences, and it's always hit something in me, and it really kind of puts things in perspective for me. It says, "We all should know that diversity makes for a rich tapestry, and we must understand that all the threads of the tapestry are equal in value no matter what their color." Now that we talked about both of these words and what they mean and how they're used, I want to talk about best practices and resources for interpretation and translation. 2 things that I have found great success with when trying to reach limited English proficiency families in Tennessee are cross-collaboration and the use of language line solutions. So we're going to focus on the cross-collaboration first. I spent the last 2 years creating and maintaining a relationship with a 501c3 nonprofit that serves the immigrant population in one of my counties. I started out just volunteering there at the facility and attending their events when possible. I wanted to put my face and my name out there, and I eventually was able to make a connection and pass out vaccine information in Spanish. We then worked together to translate a health resource pamphlet, including clinics that had Spanish-speaking practitioners, and we were able to put that at their facility. Our program has also worked with Cherokee Health System to provide Spanish interpretation services at health fairs in areas where there's a large limited English proficiency population residing. The second thing that has been very successful are language lines. Language lines can provide on-demand options in person, on the phone, or via an app for interpretation and provide translation services as well. They also offer pay per minute in case you are not going to be using these services on a daily basis. Put the language line website down below, and I also believe that Brooke will be providing a spreadsheet with some of this information to share with you after the webinar. When working with an interpreter, there are some best practices that I just want to talk about briefly. The first thing that you want to do is brief your interpreter prior to the conversation. What is this conversation about and what needs to be communicated? We need to make sure that they have an understanding of what we are trying to get across. You want to speak directly to the client or community member and not the interpreter. Talking to the interpreter can make the client feel left out of the conversation, and this can lead to miscommunication and frustration on their part, which also leads to decreased trust. We want to give time for the interpreter to relay the message and pause for delivery, using 1 to 2 sentences at a time in a natural speaking pace. You don't want to change your pace. You don't want to slow down. Just talk the way that you would and give them time to relay. Other cultures are more sensitive to nonverbal communication, so we do want to note body posture, hand gestures, facial expressions, eye contact, and how close people stand to each other. And misunderstandings often result from failing to recognize and understanding many of those forms of nonverbal communication. Something else that I wanted to talk about that you may be familiar with is comprehension. Yes doesn't always mean understanding. And in some cultures, saying yes after someone else speaks is just a sign that they're listening. It's not necessarily an affirmation yes. So we do need to clarify, and we do need to look at those other nonverbal communication strategies. Continuing on with interpretation, when we're dealing with medical information or consents, a certified medical interpreter is required by law. You can create a consent form to have the medical interpreter sign, verifying that this is protected health information, and it is protected by HIPAA, which I think all of you are familiar with. The form should be signed by the client, the interpreter, and the person obtaining the consent. We always want that third person in there. We want to avoid jargon, slang, idioms, and technical talk when possible, and we want to use living room language. Living room language is everyday language that can be understood by adults at most any age or literacy level. One thing I wanted to talk about was the teach-back method. I often use this method to ensure the information that I'm teaching about has been accurately understood. You can use this in all ages, and you don't have to use this just for limited English proficiency. I've been using this method since I started nursing 15 years ago, and I think it can be used in several different instances and scenarios, and that's why it works out so well. So step 1, we're going to use plain language to explain the information or education we're trying to get across. In step 2, we're going to ask the patient to explain what you just told them in their own words. In step 3, if there's anything that you felt they may have misinterpreted or misunderstood, we're going to re-explain. And then in step 4, we're going to repeat steps 2 and 3 until the information is understood. And something I do want to just note is we don't want to make someone feel bad if they didn't understand the information the first time. And we want to make sure that we're just trying to explain it to them again so that they get the best information possible. And it's also important to ask open-ended questions, not just yes and no questions, because like I talked about, yes and no can mean different things in different cultures. As I mentioned, this teach-back method was introduced to me about 15 years ago when I started nursing school, and it's been useful in every position that I've worked in. As you can see, you can use the teach-back method in a variety of different settings, including the hospital, emergency departments, outpatient clinics, and community health centers. With my job, I'm often out in the community, sometimes setting up for a health fair. I work with senior centers, I work with schools. So you can use this method in all of those. Any health worker who provides patients with information can use the teach-back method, and it can be delivered one-on-one in person, on the telephone, or even in a group setting. The techniques for using the teach-back are verbal information, demonstrating how to do something, and using written or visual materials. If there's one thing that I want you all to take away from today, it's that there are 11 million children in the U.S. that act as interpreters for their families, according to the U.S. Census Bureau. In recent studies, there's been a link between children interpreting for their families and increased stress. This can lead to omissions, additions, substitutions, opinions, and volunteered answers. Please do not use a family member or a child whenever you can. I wanted to share with you all a new book that was just released on Amazon from their hard copy yesterday. I've read this on Kindle, and I was just super excited to share. I think it's a great thing to have in your waiting rooms if you have those. and it's called The Interpreter by Olivia Abtahi. It's an illustrated book for bilingual children who interpret for their families or parents. And it captures a common aspect of life for immigrant and bilingual children. I wanted to share a quote from Daphne C. She's 26 and she's been translating for her parents since she was 8 years old. And she says it takes a lot of empathy and emotional energy that a child simply doesn't have. So I just want you all to kind of sit and think about that for a minute. Think about those pressures that those kids are dealing with and how hard it can be and how confusing it must be to try to be essentially the backbone of that family and make sure everything is being understood in the right way. So I wanted to share some information about when, where, and how to engage limited English proficiency families, including best practices and resources. When I first started in my current position, I didn't have a single connection in any of my counties, almost 8 counties. And with consistency, I've created trust in these communities, and I just wanted to share some of my experience and some of my advice. So, in order to work with this population, you really need to understand the population and the people. I wanted to share this chart because I think this is really interesting. It shows immigrants with limited English proficiency report more barriers to accessing healthcare and report worse health than English proficient immigrants. So as you can see, there's lower rates of a usual source of care other than the emergency room. There's lower rates of having a trusted doctor or medical professional in the United States. Lower rates of having had a healthcare visit in the past year. And then there's higher rates of limited English proficiency immigrants stating they feel that their health is fair or poor. There's a ton of value in finding trusted messengers in the community with knowledge of the cultural beliefs. You really just want to respect those cultural beliefs and you want to listen. What are the needs of the population? What are those cultural beliefs? Some cultures can be very touchy, while others find that completely disrespectful and inappropriate. So we need to understand the people that we're working with. And like I said, these trusted messengers really know what they're talking about. They're really involved in the community and those people and populations. Just briefly wanted to go over the elements of culture. You all may be familiar with some of these, but I did want to point out how many elements of culture there are. I mean, these are just a few. We could continue this list if we wanted, but I did want to point out behavioral norms like we talked about on the last slide. Something that you and I may not do ever in our daily lives may be something that someone of a different culture does every day, and we need to be respectful and non-judgmental. Some other elements of culture include attitude, customs and manners, rituals, metaphors, celebrations and ceremonies, and shared beliefs and values. Something that I do want you all to take away from this is that it is important to examine our pre-existing beliefs about people with limited English proficiency. Just because they cannot speak English as well as we do does not mean that they are not intelligent. We have so many immigrants who have fled from other countries who are doctors, physicians, lawyers, teachers. We need to treat them with the respect that we would treat people who speak English. So some best practice. We want to respect and acknowledge current beliefs and practices. And we want to come with a non-judgmental approach, as we spoke about earlier. Where needed, we can suggest Western practices in addition to the current customs and traditions. We want to make it very clear that we aren't trying to take anything away from them. We're just trying to add things that may be beneficial for them and their families. You want to immerse yourself in the community and be consistent and keep coming back. Like I said, it took weeks, maybe months, for me to actually get into a spot where I could start talking about vaccines with some of these people. And I think that it comes with building that trust. So showing your face time and time again, helping them things that may not be beneficial for your position, but are going to help build that trust. I think it's just a vital thing. Continuing on with best practices, it's important to bring resources to the people where they are. So this can include churches, daycares, local organizations such as nonprofits, schools, neighborhood community centers, and parks. Just an example of that, I have done education on a school bus that was converted into a classroom that traveled to low-income housing neighborhoods. And we did our vaccine education on the bus. Had a great time. And it's something that we had to think out of the box, but it worked out great. Providing transportation when possible to and from events is a great idea if you can do so. We've used church vans and organizational buses in the past. Providing incentives that people will actually use. I think basic needs assistance and grocery gift cards are very popular. We've used the grocery gift cards when we partnered with pharmacies and health departments in the past. And we've also passed out newborn supplies for expecting mothers. Another suggestion that I would highly recommend is offering childcare during events, especially with these limited English proficiency populations. They often have bigger families with just one source of transportation if they have a car at all. So being able to bring all the children to the space is a huge benefit and also helps with that trust. And lastly, I just want to say follow up, follow up, follow up. Make sure that they can put your face to a name and vice versa. With the limited English proficiency population, I do want to note that privacy is extremely important. We need to be aware of this. Fear that using medical services or public benefits may jeopardize the ability to secure legal status or citizenship for themselves or their families in the future. So we only want to collect information that we absolutely have to. And when we collect that information, we want them to know what we're going to use it for and who's going to have access to it. When applicable, let's allow a person to remain anonymous or use a unique identifier or first name only. So I know that some of you all use a unique identifier such as an ID number. Another suggestion is using a first name, last initial only. And if you're passing out surveys or anything like that, as I do in my position, I let them know that the surveys are completely anonymous and they are used for data collecting and information, but your name is not connected. Just wanted to say.
I'm going to go ahead and pause that right there so that you all can take down her information. Like I said, she has graciously offered to answer any specific questions too, so I'll give you a minute to get that down. But of course, I will send that in the follow-up email this afternoon too. But if anyone wants to put any more questions in the chat, please feel free to do that. Please feel free to come off mute if you thought of something else for the team, for the group, anything area specific would also be great. I also see that Chenoa added the link to the Nurse Navigators page. Thank you for doing that in the chat, Chenoa. We appreciate that. And like Chenoa said, we can get some more information about who serves where so that they can connect you all with relevant resources too. All right. Well, we are very appreciative for everyone's time today, for being here. Again, we're so sorry that Maria was sick, but we're, of course, grateful for her information, and we can get any questions to her that you all have, and we will send out tons of resources this afternoon with all the books and articles and things that Chenoa and Maria both shared, some resource sheets with some clickable links and things like that that will, of course, always be on our website. Hopefully the video is up probably by tomorrow too. So again, thank you for being here. Thank you, Chenoa, for presenting. We really appreciate your time and all of your wisdom and knowledge that you have to pass on to us. And I'll hang on for a few more minutes in case anyone has any questions, but we hope everyone stays warm and has a great Wednesday. And of course, reach out to our help desk if there's anything that we can provide support for. Thanks, y'all.